Welcome, everyone, and thank you so much for joining us today. You are in for a truly fascinating ride.
Absolutely. It's great to be here.
We are embarking on a highly curated exploration into something that you have, well, undoubtedly heard of. Maybe you've even lived with it or have family members who do, but you likely don't fully understand it on a strict mechanical level.
Most people don't, to be honest.
Right. And our mission today is to cut straight through the clinical jargon surrounding one of the most common yet fundamentally misunderstood conditions in the entire world. We are taking a deep dive into diabetes.
And it really is a condition that touches almost everyone's life in some capacity, right? Whether that's personally or just by observing the massive shifts in global public health over the last few decades.
Yeah, you see the headlines everywhere.
Exactly. Yet the actual mechanics of it, the biological domino effect that happens inside the body, that remains a mystery to the general public.
Yeah.
We tend to treat the word as a catch-all for, blood sugar issues.
Just watch your sugar, basically.
Right, which severely undercuts the complexity of what is actually a systemic cellular crisis.
Which is exactly why we are pulling from a massive, comprehensive source document today. We are breaking down a highly detailed 2026 Wikipedia master document on diabetes. And to be clear, our goal is not to just sit here and read a medical textbook to you.
That would be incredibly dry.
So dry. No,
Yeah.
our goal is to extract the most surprising, the most fascinating, and the most actionable insights from this text. We want to bypass all that surface-level advice and get right down to the core of the pathophysiology, the bizarre history, and the global impact, so you walk away truly well-informed.
And the sheer scale of the information available in this document is staggering. Primarily because the scale of the condition itself has forced an unprecedented level of global medical research.
Staggering is honestly the only word for it. Just to put this in perspective and grab your attention right out of the gate, as of 2024, an estimated 828 million people are living with diabetes.
It's hard to even conceptualize that number.
828 million. That is 1 in 7 adults globally. It is an absolute epidemic, and the numbers have completely blown past earlier medical projections. They estimated we wouldn't even hit the 783 million mark until the year 2045.
Yeah, we are decades ahead of the worst-case scenarios.
Decades.
It represents a profound, rapid shift in human health.
Mm-hmm.
But to really grasp why those macro statistics matter, we have to look inward. From a strictly biological standpoint, what happens in diabetes is a brilliant, albeit deeply flawed, mechanism.
Flawed in what way?
Well, the body is reacting to a perceived crisis in a way that makes complete logical sense on a cellular level, even though the end result is systemic damage. It's basically an evolutionary defense mechanism operating in the completely wrong context.
It's the ultimate biological paradox, and I want to start with the history of how we even identified this paradox, because the origin of our understanding is incredibly visceral. The etymology alone tells a whole story.
It really does.
The word diabetes comes from ancient Greek, specifically coined by Apollonius of Memphis around 230 BCE, and it translates directly to a passer-through or a siphon.
Which is a highly evocative image. Think about it. A siphon paints a picture of a body that cannot hold on to its own vitality, where fluids are essentially passing straight through the human form without being utilized.
Just draining away.
Exactly. And that was the primary inescapable observation in the ancient world. The Greek physician Aretaeus of Cappadocia in the 2nd century CE described it as a disease characterized by the excessive and uninterrupted discharge of urine.
And didn't the Roman physician Galen have a pretty graphic term for it, too?
He did. He went a step further and categorized it as diarrhea of the urine.
Wow. They certainly did not mince words back then.
No, they were incredibly literal.
It paints a really grim picture of a patient just wasting away. But the second half of the modern medical name mellitus bridges the gap between recognizing that massive fluid loss and identifying what was actually leaving the body, right?
Right. The addition of mellitus happened much later in 1675 by an English physician named Thomas Willis. Mellitus is a Latin word meaning honey sweet. And Willis added this classification based on a very specific, very hands-on diagnostic method.
The taste test.
The taste test. He and others before him realized the urine of these patients was literally sweet to the taste.
Which feels like a monumental leap in clinical observation, but also a slightly gross one for the physician.
Very gross by modern standards. But this sweetness wasn't just a 17th century European discovery either. Ancient Indian physicians around the 6th century CE along with Greek, Chinese, and Egyptian doctors, all noticed that the urine of these specific patients attracted ants and other insects.
Nature's diagnostic tool.
Exactly. The Indian physicians actually classified the disease as Madhumaya, which translates directly to honey urine. So without any modern blood tests, they used the natural world around them to identify the body was aggressively expelling excess sugar.
Okay, let's unpack this. They identified the symptom perfectly. The body is dumping sugar. But understanding why requires looking at the internal energy economy.
Right. We need to look beyond that outdated middle school biology analogy of insulin simply being a key that fits into a cellular lock. The actual pathophysiology is a complex, really elegant signaling cascade.
So let's break that cascade down for everyone. We consume food, which is broken down into glucose, which is the primary fuel for the trillions of cells functioning like an engine inside the body. But that glucose floating in the bloodstream cannot permeate the cell membrane on its own. It requires a transport mechanism.
Correct. So the pancreas contains specific clusters of cells called the islets of Langerhans. And within those clusters, beta cells are constantly monitoring your blood glucose levels. When glucose rises after a meal, these beta cells release the hormone insulin.
And insulin goes into the blood.
Yes. It circulates and binds to specific receptors on the surface of your muscle and fat cells. This binding triggers a complex intracellular signal, which essentially summons glucose transporters, specifically one called GLUT4, from deep inside the cell to rise up to the surface membrane.
Oh, so the transporters literally move to the surface to grab the sugar.
Exactly. Once there, these transporters pull the glucose out of the blood and into the cell to be burned for energy or stored. It is a tightly controlled, highly sensitive feedback loop.
And diabetes is the systemic failure of that specific loop. Either the pancreas stops producing the insulin signal entirely, or the cells become resistant to the signal, meaning those GLUT4 transporters never make it to the surface. Either way, the fuel gets completely trapped in the bloodstream.
And this is where we see the tragic brilliance of the body's response. Because the glucose cannot get into the cells, those cells are quite literally starving. They're completely deprived of energy.
Even though they are surrounded by it.
Exactly. So they send out biochemical panic signals. The central nervous system registers that the body is starving to death, despite the blood being absolutely overloaded with nutrient fuel.
So the body initiates emergency protocols to try and save itself.
Right. It triggers two major metabolic processes. First, glycogenolysis, which is the breakdown of stored glucose called glycogen in the liver. The liver acts as a reservoir, and it just starts dumping its reserves into the blood.
Trying to feed the starving cells.
Right. And second, it initiates gluconeogenesis, where the body starts generating brand new glucose from non-carbohydrate sources like amino acids. The liver is desperately trying to feed what it believes are starving tissues by flooding the system with even more sugar.
Which compounds the crisis exponentially. The body is drowning in glucose, yet starving for it. And this systemic failure manifests in what the medical community refers to as the classic 3 Ps of diabetes symptoms.
The physical endpoints of this internal derangement.
Yeah.
The first P is polyuria, meaning excessive urination. The kidneys act as the body's filtration system, reabsorbing essential nutrients and expelling waste. But they have a strict renal threshold for glucose. When the blood sugar concentration exceeds that threshold, the kidneys simply cannot reabsorb it all.
And the excess glucose spills over into the urine.
It spills over.
And glucose isn't just a passive molecule, right? It fundamentally changes the fluid dynamics in the kidneys.
It does. Glucose is an osmotically active molecule. Think of it like a microscopic sponge. As it passes through the renal tubules, it physically exerts osmotic pressure, dragging water out of the body's surrounding tissues and into the urine along with it. This creates a massive, unnatural volume of urine production.
That is the literal siphon Apollonius of Memphis observed all those centuries ago. The body is forcefully draining its own water to flush out the toxic levels of sugar, which instantly triggers the second P, polydipsia, or profound excessive thirst.
Yes. The fluid loss from that osmotic diuresis is so severe that it begins to deplete the intracellular water volume. The body is dehydrating rapidly, prompting the brain's thirst centers to scream for water replacement. You drink continuously, but the water just gets pulled right back out by the excess glucose.
It's a relentless cycle, and the final P loops back to the cellular starvation we talked about. polyphagia, or excessive hunger. The intracellular glucose deficiency stimulates the appetite centers in the brain.
You feel starving.
Yeah, so you eat, but because the insulin signaling is broken, the new fuel just gets trapped in the blood, restarting the entire vicious cycle all over again.
And if left unchecked, this metabolic spiral leads to diabetic ketoacidosis, which is an acute, life-threatening emergency.
That's the DKA you hear about.
Exactly. Since the body cannot access glucose, it aggressively shifts to burning fat for energy. This rapid fat breakdown floods the bloodstream with acidic byproducts called ketones. The blood pH drops, becoming dangerously acidic.
And there's a really specific scent associated with that, isn't there?
There is. A hallmark sign is the patient's breath smelling strongly of acetone, very much like nail polish remover, as the lungs try to exhale the volatile ketones.
It is a devastating cascade, but how a person arrives at this point varies wildly depending on the underlying pathology. We hear about type 1 and type 2 constantly, but looking at the clinical definitions in the text, they are functionally entirely different diseases that just happen to share the same symptom of high blood sugar.
They represent two distinct routes to the exact same systemic failure. Type 1 diabetes, which accounts for roughly 5 to 10% of all cases globally, is fundamentally an autoimmune disorder.
The body attacking itself.
Yes. For reasons that involve a really complex interplay of genetic susceptibility and environmental triggers, the body's own immune system makes a catastrophic error. It deploys T cells to specifically target and destroy the insulin-producing beta cells in the pancreas.
The factory is burned down, basically.
Completely destroyed. The body produces zero insulin. This usually presents abruptly, frequently in youth, which is why the outdated terminology was juvenile onset diabetes, though adults can and do develop it.
And then on the other end of the spectrum is type 2.
Right, comprising about 95% of all global cases.
Hmm.
Type 2 is insidious, characterized by a slow, gradual onset of insulin resistance. In this scenario, the pancreas is still manufacturing insulin.
So the factory is still working.
It's working overtime, actually. In the early stages, the pancreas often pumps out massive, elevated amounts of insulin to try and force the resistant cells to respond. But over years of this hyperinsulinemia, the overworked beta cells eventually exhaust themselves and fail.
And then you get a subsequent drop in insulin production as well?
Exactly.
The conversation around type 2 almost exclusively centers on lifestyle, diet, exercise, obesity. But looking at the genetic data from the twin studies in the source document completely rewired my understanding of the hereditary risks.
What's fascinating here is the monozygotic twin concordance rates. They are highly illuminating. When researchers study identical twins who share 100% of their DNA, the data upends common assumptions. We tend to view type 1 as the purely genetic disease. Yet if one identical twin develops type 1 diabetes, the other twin only has about a 50% chance of developing it.
Which clearly indicates that while you may inherit the genetic susceptibility-specific HLA genotypes that prime the immune system for an attack, something in the environment has to pull the trigger.
A viral infection, a toxin, something flips the switch.
Contrast that with type 2 diabetes. The concordance rate among siblings and identical twins is actually significantly higher for type 2 than for type 1.
It is.
Meaning the genetic predisposition for insulin resistance is incredibly strong, much stronger than people realize.
It demonstrates how profoundly intertwined shared genetics and shared environments are. You inherit a robust metabolic predisposition for how your body handles fat storage and insulin sensitivity, and then your built environment, your diet, and your lifestyle activate that genetic code.
And those environmental triggers extend far beyond the standard medical warnings about sedentary behavior or drinking too many sugar-sweetened beverages. There is a deeply psychological trigger detailed in the research that fundamentally shifts how we should view metabolic health.
The inclusion of psychosocial factors, particularly stress and trauma, as direct physiological triggers for type 2 diabetes is a relatively recent but massive clinical realization.
The data specifically points to adverse childhood experiences, or ACEs. We are talking about severe childhood trauma, abuse, neglect, and profound household dysfunction. The research indicates that experiencing these ACEs increases the likelihood of developing type 2 diabetes decades later by 32%.
And childhood neglect demonstrates the strongest correlation of all.
A 32% increase is a massive statistical jump.
It is, and it forces us to understand how trauma alters neurobiology. Chronic, severe stress in childhood does not remain confined to the psyche. It fundamentally and permanently rewires the hypothalamic pituitary adrenal axis, which is the body's central stress response system.
It keeps them locked in a state of high alert.
Yes. It keeps the individual in a prolonged state of fight or flight, chronically flooding the bloodstream with stress hormones like cortisol.
And cortisol actively antagonizes insulin.
It does. Cortisol's primary evolutionary function is to mobilize energy for immediate physical action. It tells the liver to dump glucose into the blood, and it simultaneously creates temporary insulin resistance in the muscles so that the glucose remains available for the brain and the immediate escape response.
For running away from a predator.
Exactly. But when a child experiences relentless trauma, that cortisol flood never subsides. Over decades, this chronic hormonal barrage structurally damages the body's insulin sensitivity, completely independent of what they're eating.
Wow. It completely reframes the disease from a simplistic moral failing of eating poorly into a complex biological history of survival. And that complexity deepens when we look at the diagnostic gray areas. The World Health Organization actually classifies diabetes into 6 distinct categories, recognizing that the binary of type 1 and type 2 is clinically insufficient.
There are several rare or frequently misdiagnosed forms of the disease that blur the lines between autoimmune and metabolic dysfunction.
Here's where it gets really interesting. Let's explore LADA first. Latent autoimmune diabetes of adults. In medical circles, this is sometimes unofficially referred to as type 1.5.
LADA is, at its core, type 1 diabetes. It is a targeted autoimmune destruction of the pancreatic beta cells. However, the progression is remarkably slow, and it presents in adulthood.
Which creates a massive diagnostic blind spot.
Huge.
A 45-year-old patient presents with rising blood sugar levels. Because of their age, the attending physician defaults to a type 2 diagnosis, assuming it's insulin resistance. They prescribe lifestyle modifications and metformin.
But those interventions will inevitably fail because the root cause isn't resistance. Their beta cells are quietly being eradicated.
Exactly. They have some residual insulin production, which delays the onset of severe symptoms like ketoacidosis, but they are slowly marching toward absolute insulin dependency. It is a tragic misclassification driven purely by demographic assumptions.
Then you have conditions driven by highly specific genetic anomalies like MODY or maturity onset diabetes of the young.
The name itself sounds like a clinical contradiction. Maturity onset of the young.
It is a historical artifact from earlier hypotheses. MODY is exceedingly rare, accounting for only 1 to 2% of cases. Unlike type 1 or type 2, which involve highly complex polygenic webs of multiple genes interacting with the environment, MODY is an autosomal dominant inherited form. It is caused by a single gene mutation.
Meaning, if one parent carries a mutation, a child has a 50% chance of inheriting the disease directly, regardless of lifestyle or autoimmune factors.
Precisely. And because it traces back to a singular genetic defect, researchers have identified at least 14 distinct subtypes of MODY, depending on exactly which gene is broken.
That's incredibly specific.
It is, and the clinical significance of recognizing MODY is profound, because many patients with certain subtypes can manage their blood sugar entirely with oral medications called sulfonylureas, or even just through diet. They bypass the need for lifelong, burdensome insulin injections that a misdiagnosis of type 1 would bring.
Which would be life-changing for a patient. And moving from genetic anomalies to environmental extremes, we have type 5, which is the unofficial designation for malnutrition-related diabetes.
This form of the disease really highlights how fragile the pancreas is under severe physiological duress. In type 5, the pancreas ceases to produce insulin, similar to type 1, but there is no autoimmune attack.
It's just starvation.
Yes. The destruction is caused by severe, chronic, long-term malnutrition. The starvation literally atrophies the pancreas, destroying its endocrine function.
But they don't get ketoacidosis.
Curiously, no. These patients rarely develop the dangerous ketosis seen in type 1. The World Health Organization actually maintained a specific diagnostic code for this in the 1990s. While they later deprecated it in their official taxonomy to streamline classifications, researchers in developing nations still heavily utilize the concept to describe the metabolic fallout of chronic famine.
The research also wades into some deeply controversial, cutting-edge theories, specifically regarding cognitive decline. There is a growing body of researchers referring to Alzheimer's disease as type 3 diabetes.
It is a chilling paradigm shift in neurology. Researchers are finding compelling evidence of severe insulin resistance localized entirely within the brain tissue.
So just the brain cells are resistant.
Right. The neurons in the brain, much like muscle cells, rely heavily on insulin signaling to absorb glucose for energy. If the brain develops insulin resistance, those neurons lose their ability to access fuel. They effectively starve, leading to synaptic breakdown, memory loss, and the progressive cognitive decline characteristic of Alzheimer's.
That is terrifying.
It is. While the broader medical community has not universally adopted the type 3 label, primarily to avoid confusing patients with classic diabetes, the metabolic connection between brain health and insulin signaling is currently one of the most intensely studied areas in neuroscience today.
And as if the individual types weren't complex enough, the pathology can actually stack. The research details double diabetes, a scenario where a patient who already has classic type 1 diabetes, meaning they produce zero endogenous insulin, subsequently develops the hallmark feature of type 2 systemic insulin resistance.
It's a double blow.
Right. They are injecting the required synthetic insulin to survive, but their body's tissues begin ignoring the synthetic signal due to weight gain, chronic stress, or genetic predisposition. It requires massive, ever-increasing doses of insulin just to maintain a baseline.
It is a stark reminder of the compounding nature of metabolic dysfunction. When the energy economy breaks down, the resulting damage is never isolated.
So, what does this all mean when we zoom out? Which transitions us to the macro impact. When we look at the 828 million people affected, the economic and physiological toll is almost incomprehensible. The global expenditure on diabetes-related healthcare sits at an estimated $760 billion annually.
It's a staggering drain on resources.
And it is currently the 7th leading cause of death globally. But what is truly alarming is the geographic shift in prevalence.
The epicenter of the epidemic is moving rapidly. Historically, diabetes was viewed as a disease of affluent, developed nations. Today, the most dramatic, explosive increases in prevalence are occurring in low- and middle-income nations, particularly across Asia and Africa.
More than 80% of all diabetic deaths now occur in these regions.
Exactly. This shift is driven by rapid urbanization and the global nutrition transition. As populations move from agrarian lifestyles with high physical activity into densely packed urban centers with sedentary labor, the environment changes completely.
The food system changes entirely.
Traditional fiber-rich diets are aggressively replaced by the Western-style diet foods engineered for maximum shelf life and caloric density, loaded with saturated fats, refined carbohydrates, and added sugars, completely stripped of nutritional value.
It is a forced, rapid environmental change that outpaces our genetic adaptation. But to understand the true cost of this disease, we have to look at what that prolonged exposure to high blood sugar actually does to the human anatomy over decades. Hyperglycemia is effectively toxic to the vascular system.
It destroys the blood vessels. The long-term complications are medically divided into two categories based on the size of the blood vessels being destroyed: macrovascular and microvascular.
Let's start with macro.
Macrovascular complications refer to the damage inflicted on the body's large arteries. Chronic high blood sugar damages the delicate endothelial cells lining the blood vessels. This damage accelerates atherosclerosis, which is the hardening and narrowing of the arteries due to plaque buildup.
And that leads to heart attacks.
Yes. As a result, diabetes doubles the risk of cardiovascular disease. Roughly 75% of all deaths in diabetic patients are ultimately caused by coronary artery disease. It also drastically elevates the risk of severe strokes and peripheral artery disease, choking off blood flow to the limbs.
But the microvascular complications, the destruction of the microscopic, fragile capillary beds, are where you see the most specific, localized devastation.
These tiny vessels bear the absolute brunt of the toxic sugar load. In the eyes, this manifests as diabetic retinopathy. The capillaries feeding the retina weaken, leak fluid, and hemorrhage, making diabetes the leading cause of new-onset blindness in working-age adults.
And what about the kidneys?
In the kidneys, it causes diabetic nephropathy. The microscopic filtration units, called glomeruli, are essentially scarred and destroyed by the osmotic pressure and sugar toxicity. This accounts for over 50% of all patients requiring dialysis in the United States.
Over half of all dialysis patients.
Yes.
And then there's the nerve damage, diabetic neuropathy.
Neuropathy is perhaps the most insidious complication. The high glucose levels damage the vasa nervorum, the tiny blood vessels that supply oxygen and nutrients directly to the peripheral nerves.
So the nerves are literally suffocating.
Yes, the nerves begin to die. This manifests initially as agonizing neuropathic pain, tingling, or a complete loss of sensation, typically starting in the extremities like the toes and feet.
And that sensory loss is what creates the pathway to amputation.
Exactly. If a patient cannot feel pain in their foot, a minor injury, a blister from a tight shoe, a small pebble goes completely unnoticed. Because the macrovascular disease has already compromised blood flow to the area, The immune system cannot reach the wound to heal it.
So it just worsens.
It ulcerates, becomes deeply infected, turns gangrenous, and necessitates surgical amputation to save the patient's life. Diabetes remains the undisputed leading cause of non-traumatic lower limb amputations globally.
It's horrific, and the secondary complications extend even further. The research links chronic diabetes to significant hearing loss, an elevated risk of gallstones, and as we discussed with the brain metabolism, a significantly higher risk of vascular dementia and cognitive decline.
And the earlier in life a patient is diagnosed, the steeper that trajectory of cognitive decline becomes.
When you map out that level of systemic whole-body failure, it becomes clear that surviving diabetes requires immense resources. And those resources are not distributed equally. The sociological data surrounding this disease reveals glaring structural inequalities.
If we connect this to the bigger picture, looking objectively at the demographic data, particularly within the United States, the disparities are stark. While the average U.S. adult faces a roughly 40% chance of developing type 2 diabetes in their lifetime, Hispanic and Latino adults face a greater than 50% probability.
More than half.
African-American populations also face disproportionately higher rates of diagnosis and complications compared to white Americans.
And beyond the socioeconomic factors, there are distinct physiological differences in how different populations manifest the disease, too. Asian populations, for example, have a significantly elevated risk profile at lower thresholds. They tend to develop insulin resistance and type 2 diabetes at a much lower body mass index compared to other populations.
Which fundamentally alters the diagnostic criteria.
It has to, right?
It has to. The distribution of visceral fat, the dangerous, metabolically active fat surrounding the internal organs, is structurally different. They can develop the disease at a younger age and with lower overall body fat. The danger here is that standard screening guidelines, which rely heavily on generalized BMI cutoffs, often miss these patients entirely.
They don't look at risk on paper.
Exactly. The research indicates that diabetes is severely underreported in Asian American communities, with an estimated 1 in 3 cases going completely undiagnosed until severe microvascular complications appear.
The economic divide is just as lethal. A 2010 public health metric cited in the document showed that diabetes-related emergency room visits were wildly disproportionate based on income. Rates were more than double for individuals from the lowest income communities compared to those in the highest tax brackets.
Because poverty directly restricts access to preventative primary care.
Right, and it heavily limits access to fresh, nutrient-dense foods and often dictates living in environments lacking safe infrastructure for physical activity. This drives up both the initial incidence of the disease and the severity of the terminal complications.
And compounding the physical and economic burden is the psychological toll of societal stigma. There is a pervasive, highly destructive public narrative that frames type 2 diabetes purely as a moral failing, a disease of laziness and gluttony.
A narrative that completely ignores the established science on genetic heritability, the visceral impact of childhood trauma that we just discussed, and the structural realities of food deserts and poverty.
And the stigma yields highly documented negative clinical outcomes. The research details how this prejudice affects social standing, employment opportunities, and in certain cultures, even marriage prospects. Internally, the self-stigma drives profound shame, leading to significantly higher rates of clinical depression.
Patients often conceal their diagnosis, don't
Yes, they avoid testing their blood sugar in public, and they delay seeking critical medical interventions, leading to poorer long-term survival rates.
The data also highlights a severe gender disparity in how the burden is carried. Women experience markedly higher rates of mental health comorbidities stemming from diabetes management, including specific eating disorders tied to insulin emission for weight control.
Which is incredibly dangerous.
Furthermore, societal pressures and the lack of systemic support mean women are 3 times more likely to become housebound due to the complications of the disease. And perhaps the most glaring inequity, the clinical data shows that while women actively seek out more medical assistance for their diabetes than men, they statistically receive less aggressive treatment and fewer therapeutic interventions from healthcare providers across the same racial and economic demographics.
The bias is baked into the care.
The text also briefly notes the compounding challenges faced by transgender individuals who report systemic barriers to receiving inclusive preventative diabetes care.
It paints an objective picture of a metabolic crisis that ruthlessly exploits existing societal fault lines.
So, when faced with this level of systemic breakdown, how does modern medicine intervene? How do we artificially manage a siphon that refuses to close?
The entire philosophy of management is centered on mimicking the healthy pancreas's tight control over blood glucose. The clinical objective is to maintain blood sugar levels as close to the normal physiological range as possible, thereby delaying or preventing the toxic macro and microvascular damage.
And the gold standard for tracking that success over time is the HbA1c test.
Yes, the A1C.
Instead of just a daily finger prick showing a momentary snapshot, the HbA1c measures glycation. It essentially calculates the percentage of hemoglobin proteins in your red blood cells that have become coated with sugar.
Since red blood cells live for about 120 days, this gives doctors a highly accurate 2 to 3 month average of your blood sugar control. For most patients, the therapeutic goal is maintaining an HbA1c below 7%.
Achieving that target requires entirely different strategies depending on the pathology. For type 1 diabetes, because the endogenous insulin production is zero, there is no biological workaround. The patient must manually replace the missing hormone.
This is conventionally managed via a basal bolus regimen. The patient injects a long-acting basal insulin to provide a steady background level, covering the body's basic metabolic needs throughout the day, coupled with rapid-acting bolus insulin injections, calculated and timed precisely with every meal to handle the immediate influx of dietary carbohydrates.
For type 2 diabetes, because the underlying issue is cellular resistance and metabolic dysfunction rather than an absolute lack of insulin, the intervention pyramid is much broader. The foundational tier is intensive lifestyle modification.
And the clinical data is robust here. Engaging in high levels of physical activity, specifically exceeding 90 minutes of exercise per day, is associated with a massive 28% reduction in the risk of developing diabetes.
90 minutes is a lot, but 28% is huge.
Furthermore, significant weight loss, particularly the reduction of visceral fat, can sometimes force type 2 diabetes into a state of partial or even prolonged remission, restoring beta cell function and insulin sensitivity.
But when lifestyle modifications are insufficient to overcome the genetic and environmental resistance, pharmacological intervention becomes necessary. The universal first-line oral medication is metformin.
It is a brilliant, decades-old drug that targets the liver's panic response. Metformin specifically suppresses gluconeogenesis, telling the liver to stop manufacturing and dumping excess glucose into the bloodstream, while simultaneously increasing the peripheral tissue's sensitivity to the circulating insulin.
And the pharmaceutical arsenal has expanded dramatically in recent years with entirely new classes of drugs. SGLT2 inhibitors physically force the kidneys to lower their reabsorption threshold, actively flushing excess glucose out through the urine.
And the GLP-1 agonists.
Yes, GLP-1 agonists mimic the body's natural incretin hormones, stimulating the pancreas to release more insulin only when food is present, while significantly slowing gastric emptying and signaling satiety to the brain, which often results in profound weight loss.
Beyond pharmaceuticals, we're also seeing mechanical and surgical solutions applied to this metabolic crisis. Bariatric surgery, various procedures that physically alter the digestive tract to restrict food intake and alter gut hormones, is highly effective. It frequently allows patients with severe type 2 diabetes to maintain normal HbA1c levels with minimal or completely eliminated reliance on diabetes medications.
But the surgical intervention that I found the most surprising deals with the neuropathy we discussed earlier. The prevailing medical theory has long been that diabetic nerve pain is exclusively a chemical death, the toxic sugar levels simply asphyxiating the peripheral nerves. But the research introduces multiple nerve decompression surgery.
Right. It applies an orthopedic mechanical solution to a metabolic problem.
Huh?
The elevated blood sugar causes the peripheral nerves to physically swell and increase in volume. Because these nerves run through naturally tight anatomical bottlenecks in the human body, like the carpal tunnel in the wrist or the tarsal tunnel in the ankle, the swollen nerves become physically entrapped and compressed against the surrounding ligaments and bone.
So the pain isn't just chemical, it's an extreme, chronic pinching of the nerve.
Correct. Surgeons can intervene by physically snipping the tight, constricting ligaments, thereby decompressing the trapped nerve. The clinical outcomes are remarkable. Decompression surgery is strongly associated with dramatically lower pain scores, the physical restoration of sensation in the extremities, a massive reduction in the formation of foot ulcers, and ultimately, a significant drop in the amputation rate.
It really highlights how intertwined the metabolic and mechanical systems of the body truly are. And speaking of physiological connections, I want to make a fascinating pivot. In examining all this human suffering, this global epidemic, the research provides a surprising aside. We are absolutely not alone in this metabolic struggle.
No, we aren't.
Diabetes exists robustly throughout the animal kingdom.
The veterinary data is extensive. Domestic dogs and cats develop diabetes at remarkably high rates, and the epidemiology mirrors our own in bizarrely specific ways.
The demographics for our pets are incredibly distinct. For dogs, the disease overwhelmingly strikes middle-aged females, who are twice as likely to develop the condition as their male counterparts. Furthermore, genetics play a huge role, with certain small breeds, specifically miniature poodles and Samoyeds, carrying an exponentially higher risk profile.
Conversely, the feline data skews in the opposite direction. Certain studies indicate that male cats are significantly more prone to developing diabetes than females. There are distinct genetic breed predispositions here as well, with the Burmese, Russian Blue, and Abyssinian breeds showing elevated risk. And much like the human epidemic, overweight and obese felines represent the vast majority of cases.
Feline diabetes is actually shockingly similar in its pathophysiology to human type 2 diabetes, isn't it?
It is. The cats develop severe insulin resistance driven by obesity and inactivity, followed by beta cell exhaustion. And the treatment protocols for both Fido and Fluffy are identical to human interventions.
Aggressive weight management, highly specific low-carbohydrate diets, oral anti-diabetic medications, and daily subcutaneous insulin injections.
Yep. Pet owners have to learn to monitor their animals for the exact same lethal ketoacidosis that human patients face.
However, looking across the broader animal kingdom, the research highlights a staggering evolutionary anomaly. While mammals struggle with glucose regulation, birds never get diabetes.
Never.
Not a single avian species.
It does not exist in their pathology. Their metabolic engine operates on an entirely different physiological paradigm. Birds naturally circulate blood glucose at extraordinarily high concentrations levels that would instantly trigger severe osmotic diuresis, blind a human, and utterly destroy a mammalian kidney within weeks.
Wow.
Yet, they have evolved a complete natural tolerance to this glycemic load. Their endothelial cells and microvasculature are structurally immune to the toxic effects of the sugar.
It makes you wonder if the key to truly curing the vascular damage in humans lies somewhere in the genetic sequencing of a pigeon's kidney. It is a profound biological mystery.
It absolutely is.
And that evolutionary quirk brings us to the end of our journey today. We have covered a truly massive amount of ground, exploring a condition that touches billions of lives. We started back in 230 BCE with Apollonius of Memphis recognizing a devastating siphon, tracked through the visceral reality of honey urine diagnostics, and unpacked the deeply complex internal cellular cascade of insulin signaling and glucose transport.
We examined the hidden diagnostic spectrum moving beyond the binary of type 1 and type 2 to recognize the slow autoimmune decay of LADA, the single gene mutations of MERY, the atrophy of malnutrition, and the terrifying prospect of Alzheimer's as localized brain starvation.
We looked impartially at the objective sociological data, documenting how this 828 million person epidemic exploits poverty, punishes marginalized populations, and fundamentally alters global economics. And we explored the arsenal of interventions we deploy to fight back, from GLP-1 agonists to mechanical nerve decompression, for both ourselves and our miniature poodles.
This raises an important question to consider as we close. We know from the epidemiological data that the explosive global rise of this disease is fundamentally driven by globalization, rapid urbanization, and the aggressive expansion of the Western diet. These are not individual failings. These are massive societal shifts.
Structural shifts.
Exactly. So the question we must ask is this. If our modern built environments, our sedentary labor structures, and our global food supply chains are inherently diabetogenic, meaning they are literally engineered in a way that shatters our natural metabolic limits, can we ever expect pharmaceutical treatments and insulin injections alone to save us? Or will stemming this epidemic require us to radically, systematically redesign our cities, our work lives, and our global agriculture to finally match the ancient genetics we still carry?
A heavy, complex, but absolutely necessary thought to end on. Thank you so much for joining us on this deep dive into the source material. We hope you walk away with a richer, more profound understanding of the mechanics and the magnitude of a condition that shapes so much of our modern world. Keep questioning the systems around you, keep looking for the bigger picture, and we will see you next time.